everyone. Thank you for having me today. So, yes, you advertised it as 8 and then you talked about 10. I hope no one's excited to hear 10. I'm going to talk about, I came up with 8 of the most common childhood infections. If you're thinking, well, basically whatever presents to pediatricians is generally infections. Infections are kind of synonymous with illness in children because in young kids, communicable diseases seem to predominate versus adults. So it's not a very technical talk. I really wanted to have a look at the common things that affect kids and bring them to doctors in general, GPs, outpatient departments, pediatricians, as well as to inform anyone who might be parents out there to tell them what's important to know. So starting at the top of our head to toe, I thought I would discuss head lice, otherwise fancier known as pediculosis capitis. And this condition is caused by the Pediculus humanus capitis organism, which is basically very similar to Pediculus humanus corporis, which is the body lice, but apparently there's one single gene that's changed, but otherwise they are almost identical to the eye or the microscope, and they look similar to each other but different to pubic lice, which are otherwise known as crabs and have a different kind of shape and description, and that's called Pthyrus pubis. Yeah, and you generally won't find the head lice on the body or vice versa. They seem to stick to their areas. So I just think it's important to cover some true facts about lice. Who are generally lice infestations generally affect kids sort of between the age of 3 and 11 years. Generally, kids who are school going, tends to be girls more than boys, possibly because of the behavior in which girls engage. And this here in the picture is an example of girls having a slumber party, playing with each other's hair, getting really close together. It happens all over the world. It crosses socioeconomic strata, but overcrowding does obviously increase the spread where people are closer together. They like the head. Rarely, I think if you've got a really big infestation, you might find some on the eyelashes or the eyebrows. And the way it's spread is by close interaction between people, the head of hair, less so by brushes and hats and things that touch the head and get hair on them. And it's important to know that lice do not jump, they crawl, and even apparently walking on a flat surface isn't easy for them. So they like to crawl on heads, basically. And when they do most of their activity is at night. So technically a girl slumber party is the perfect setting for lice to be spread. What is the louse? It's an ectoparasite. It is technically an insect because it has 3 pairs of legs. What people generally call the nits are, they actually probably describing the eggs. Usually they actually say the empty eggs, which are left on a shaft of hair, but that's what you would see. And then there's the adults. There's also nymphs, and then there's the adults, which are, they say, sort of the size and appearance of a sesame seed, 2 to 3 millimeters. Females are bigger than the males. They basically crawl onto a new host directly. They have to be in close contact, and they can sometimes be via the fomites I mentioned already. The females, once they're adults, lay eggs between 4 to 8 per day. So in their lifespan can lay over 150 eggs. They usually lay these eggs near the scalp, a few millimeters from the scalp, and these are cemented to the hair shaft. And then they will move slowly outwards with their hair. So, you know, if they stick around for a month, these nits or empty eggs, you can see them further from the scalp. They like to lay their eggs near the nape of the neck and behind the ears in that area of hair. The eggs don't leave the hair. They can survive a few days, if you think, but if an egg on a hair happens to fall on the ground, they can actually survive a few days off the host, and it takes about a week or so to hatch, and then 1 to 2 weeks to get to develop from the baby to the adult. And the adult needs to take blood meals regularly to survive, and it needs the warmth and the blood from the host. The adult can live up to a month, and off the host, they can only survive about 1 to 2 days if there's without the host's blood to survive. It's difficult to see actual lice adults in the hair. They tend to hide very quickly. They are small. It's easier to see the nits near the base of the hair. and they tend to somehow be darker on darker hair and lighter on lighter hair. What is not true is, so fiction is that lice can spread disease. It's not fun to have lice, but they don't actually spread disease, basically hardly ever, which is versus, as opposed to body lice, which can spread lice-borne typhus, lice-borne trench fever, and lice-borne relapsing fever. They are, it's not true that they're associated with poor hygiene or dirty hair. In fact, you might have heard that they prefer cleaner hair. It's not true that they spread by simply anything that touches heads, like backpacks that sit near your head or headrests. It's not true that they could jump from head to head. They do need to be in close contact to actually crawl. I think it's just presumed that eggs or lice would infest the environment around a host, and that you've got to sort of, when you've got a child with lice, you need to basically move house. They're not really all over the place. It's not true that they spread from dogs, cats, or birds. They do also get lice, but the lice.
Lost Judy. Looks like we lost Judy for a second. Let me just get it back quickly. Sorry.
Did I mute myself? Can you hear me?
Yes, we can. I think we just lost you for a second there, but yeah,
I don't know what happened.
You're just
Okay,
going to
so
share, you're going to need to share again as well. Sorry. I think the reception just dropped.
sorry.
No problem.
It's always a problem for me because I'm not good at this.
It was sounding.
I'll probably just go to no. I'll get there. Can you see and can you hear now?
Yep, sounds perfect.
Oh, thank you. Okay, so the symptoms of lice are itching, and this is caused by anticoagulant and anesthetic that is usually injected into the host skin, and it can cause an allergic reaction. So not everyone itches, only some people, probably most, will be in some way react to this. But this actually takes about 4 to 6 weeks after the infection. And it does happen sooner, even within days, if they've had a previous or if they have a heavy infestation. Having lice tends to disrupt sleep, and so irritability is common during the day of these kids, for these kids who have lice, but it can also be asymptomatic. So the diagnosis is usually made by visual inspection, and I'm sure many people who have kids have heard that they go to the nurse at school on a certain day, I don't know how often, so that they can check if anyone has lice. So you should be able to see them, or the eggs at least. And don't panic, because sometimes it can be confused with hairspray that's dried in little flakes, or hair gel, or dandruff. And you can look for the moving lice, but more likely you're going to see the pale nits attached to the hair shafts. And you can also use these very fine lice combs and actually inspect them. So if they're further away from the scalp, you might see the empty hatched eggs, and even if it's far away from the scalp, this might probably mean a past infection, but with the eggs still cemented to the hair. The treatment for lice is, not many people are going to do this, but shaving the head would sort out the problem, basically. Lice combs seem to be very useful, and you can probably put something like conditioner or something in the hair beforehand to help it ease through the hair, but it needs to be a very fine tooth comb. And if you did this regularly, every few days, and get the eggs off, even though you're not attacking the adults, you could ultimately end the infestation once you've gotten rid of the eggs and the adults on the scalp have died. Quicker solution would be pediculicidal shampoo that kills the lice. And this is pyrethroids like permethrin, organophosphates like malathion. And I don't think people use this lindane as often anymore because it is potentially toxic. Of course, they all are. And when you hear the word organophosphates, you can imagine that some people might be a bit reluctant to use these products on their children's heads. Also, resistance has emerged. Whereas there's a nicer, newer sounding one, dimethicone, which is a silicone-based polymer, and essentially it creates a sort of a greasy layer which suffocates the lice. So this is safe. And in fact, if anyone has used Telemint drops before, which moms of babies like to give them to help them burp, that's actually also dimethicone or simethicone, but it's related, and it's taken orally. So this is not a toxic substance. No resistance is going to be to emerge to this because it's not taken in by the organisms at all. When you do put these things on, you usually need to leave it overnight. Washing it and taking it straight off probably won't do the trick. And this doesn't usually kill the eggs, only the nymphs and the adults. So you would, if you really want to make sure they're gone, you should treat again after 1 week. But one can understand why there might be some concerns about some treatments. Ideally, starting at the top, everyone in the household should be treated, whether they're symptomatic or not. You should wash the bed linen and the clothes that were recently used and probably touched the child's head or the person's head in a hot wash. That must be about 54 degrees Celsius, and dry them on high heat to kill get rid of the eggs and the adult. Usually it would be the eggs. If you have items that are not washable, dry cleaning is effective, or you can just seal the items in a plastic bag for 2 weeks, forget about it, and then use them again. Combs, brushes should be soaked in hot soapy water for 5 to 10 minutes, and vacuuming the area inhabited by the host, ideally to pick up any, probably you're not going to find many eggs lying alone or lice, but possibly hairs with eggs attached, so you can vacuum that area. But again, in terms of what isn't true, when it comes to treating, it's not necessary to panic. But you know, in all the movies, when some child has lice, everyone panics. It's not necessarily to go berserk and sterilize everything in the home. Things like mayonnaise and various oils at home, eliminating an infestation, that's unlikely going to work. So people have said, let's put mayonnaise on the hair. But some things that have been shown to possibly work are tea tree oil, aniseed oil, coconut oil, but you need repeated applications for quite some time. And essentially, probably that combing through the hair with the lice comb is probably what's working. It is not necessary for children with lice to stay out of school until the lice infestation is cleared. This is just going to add more stigma to the whole condition. But basically, children should know they must avoid close contact, putting their heads near each other, sharing things like brushes and hats and things, and just make sure that that person and their family knows to treat, and that should be sufficient. It's not correct that the treatment will kill the eggs. It doesn't. So like I said, repeat your shampoo the next week. And treating the adults isn't sufficient because you need to physically remove all the eggs to eliminate the infestation. So I'm just wondering how many people are currently itching their scalps, because generally just talking about lice makes someone itch. So another common childhood condition that would come to an outpatient setting is tinea capitis, which I find sometimes quite confusing, easily confused with impetigo. And I think I sometimes wait, should we treat this as a bacterial infection? Is this fungal? Because they can look quite similar. So the two pictures on the left are pictures of tinea capitis, and on the third and the fourth are more likely impetigo. So there should be some clear differences, but sometimes there is a mixture of the two conditions, so it might be a bit difficult. But tinea capitis would be transmitted by shared items. It's caused by trichophyton or microsporum species of fungi. And looking at it, it often causes hair loss, and where the hair actually breaks off at the scalp. And you should see a sort of a denuded area with an edge of scale around the lesion, and it's not usually painful. But you can sometimes have this deeper collection, which is called carrion, which would make a soft fluctuant mass below your what you can see on the surface. And then bacterial folliculitis, which would be little infection around each hair follicle, which would be bacterial, or impetigo, which is infection of the skin, bacterial infection. This is usually introduced through trauma. So if the head was shaved, or if there was an injury, I guess, or if this child scratches a lot for some other reasons. But again, this can be quite confusing because some parents if they've seen the tinea, and so they shave the head, and now there might be an element of impetigo as well, and that's where it sometimes gets confusing. The organisms here are usually Staph aureus and Strep pyogenes. This, though, less commonly causes alopecia, and the hair would tend to grow through the area that's infected. The process is usually papules, which then rupture and form this small golden yellow crust on the surface, and this tends to be more painful. If extensive, neglected, not treated properly, it can actually cause an abscess. In both of them, you can get local lymph nodes, so that doesn't really help us. So the treatment for tinea capitis, I think everyone knows this, but it has to be oral. Topical treatment isn't going to do the trick. And we know that it has to be prolonged treatment of 4 to 6 weeks. The options are terbinafine, itraconazole, fluconazole, and griseofulvin. I think we often have a problem because for ages we haven't had access to griseofulvin in the hospitals. But and griseofulvin was quite tricky, I think, as well as itraconazole, they need to be taken with fatty food. So generally these days, and probably just as effective and easily tolerated, is fluconazole, and certainly I'm sure if you're in private practice, you can get hold of terbinafine. I think the question everyone gets a little confused about is, are we now going to give fluconazole every day, or are we going to give it weekly? Because people have heard both. So fluconazole weekly is actually advised in the guidelines at a dose of about 8 milligrams per kilo per day, once a week. If you're going to give it daily, they give around 5 to 6 milligrams per kilogram per day. Topical shampoo is not sufficient. That's the problem. Sorry, I've said it actually incorrectly. Fluconazole daily is actually advised because the chances of a parent remembering to give their child the weekly dose is probably minimal. So they actually are advising a slightly lower dose, but daily. If you're worrying about a bacterial infection, you can use topical, something like mupirocin or fusidic acid, or if it seems more extensive, then you might want to use oral antibiotics. And if you do believe that there is a combination of both, you could use something topically and then also treat the tinea capitis. Moving on to sinus, I put it in inverted commas like that because so often parents say my child suffers from sinus, and I'm not quite sure often what that means. I think everyone diagnoses a child with a blocked nose that goes on a bit as having sinus problems. And we often also see it diagnosed on CT scans, which I'll come to. So just to remember, the sinuses aerate at different times, but you can get during childhood, but you can get sinus infections in the first year of life even. But it's important to know that acute rhinosinusitis, as dramatic as that sounds, is basically a part of every viral upper respiratory tract infection where you have a mucosal lining. If you're making snot in the nose, you're probably making the same kind of mucus in the sinuses as well. But that doesn't mean it always needs treatment. So just to discuss what are our actual concerns and potential complications, what are we worried about in these circumstances, and how do we diagnose acute bacterial rhinosinusitis? So what's important to know is, like I just said, we know viral upper respiratory tract infections are hugely common in childhood, hence the common cold. And about between 6 and 8% will be complicated or followed by some bacterial infection. Obviously, it's not known exactly because not everyone presents, not everyone is tested. And in 80% of cases of acute bacterial rhinosinusitis, there was a known preceding viral upper respiratory tract infection. So they do often follow on. Unfortunately, upper respiratory infections produce vast numbers of medical visits and prescriptions each year for probably unlikely unnecessary antibiotics. Complications are rare, but in our setting, certainly in our state sector, we see more complications, and they can be potentially serious complications because they're very close to the meninges, the brain. There can be involvement of the venous sinuses, and the orbit is right there, so you can get orbital cellulitis as well. The organisms in acute bacterial sinusitis tend to be, although they say that viruses are generally the start of it, by the time they've actually done studies, they don't usually, and obviously this isn't routinely done, but when they've actually looked at it, they haven't found the viruses. That in older studies, they weren't really using our new PCR techniques. They were using culture, but also often the virus would have disappeared by the time they present. But so it's usually the bacteria, the strep pneumoniae, which we're seeing less common than before because of our vaccine, the pneumococcal vaccine. But the ones we're seeing are tending to be more penicillin resistant, Haemophilus influenzae, that non-typable, and these are becoming relatively more common than the strep pneumo. But they are having more beta-lactamase production, and Moraxella catarrhalis, which is almost always a beta-lactamase producer. And it's just important to know if when you send patients for CT scans, for other reasons, and one of the comments is that they see mucosal sinus changes suggestive of sinusitis. This does not mean that every patient on whom you see this needs treatment, unless they were presenting with other features. Okay. So just the natural history of the common cold, I think we all know this, that it starts with the nose, being blocked, some throat irritation, little bit of low-grade fever, possibly not feeling well. Then you get the nose symptoms, the sneezing with the watery discharge, which often becomes a bit thicker and might change color, and that usually gets parents worried that now they need an antibiotic, or people themselves think they need an antibiotic. And a lot of the time, a cough also is part of this whole process, and this can even persist up to 10 days. So if you were to look at it, again, you all know this, everyone's had this, little bit of a fever, not in everyone at all, and usually just for the first few days. Sore throat, again, not in everyone, first few days, usually gone by 7 to 10 days. Coughs, not in everyone, but they can linger a bit and gradually get less and less by 2 weeks. And the nasal discharge is often there most in the first few days and in a lot of the people, and then slowly getting less and less. So you can give antibiotics at any time here. Please don't. These are not going to affect the outcome. It's not like giving the antibiotics will prevent it getting worse or even change anything. So they have found that there's the acute bacterial sinusitis usually conforms to one of 3 patterns. Either they had the symptoms of the upper respiratory infection with the cough, blocked nose, or both, and it persists. It must be more than 10 days, but not longer than 30 days to call it this, and it just doesn't get better. And often we do need to actually ask the parent, wait, did they, especially if a child is at creche or nursery school or at school, maybe they sometimes got better and then they got a new infection. Did this persist? The rhinorrhea can be of any quality. That doesn't make any difference. The cough can be wet or night, occurs in the daytime, but it's worse at night. And basically the hallmark is this persistence. It's just gone on. The patient might not actually appear particularly ill. They might have a low-grade fever. And if you were to look nicely into the nose, the nasal cavity, which I don't think we tend to often do, you might even see a discharge visible on the turbinates. Then you've got the other presentation where the symptoms are severe from the onset, and they would present with a high temperature of at least 3 to 4 days duration. It wasn't just those first day or 2. And the fever is accompanied by rhinorrhea that is suggestive that it's infected. And then the third type is where there's worsening symptoms. So there was like a biphasic illness where there was the initial upper respiratory infection symptoms and then got a little bit better and then got worse again, which usually comes in after about a week of the illness. And now there's fever, an increase in the nasal discharge, a daytime cough, or all of the above. So just to sum it up, you either have persistent symptoms more than 10 days, severe symptoms from the start, or worsening symptoms after a period where they seem to resolve for a bit. And from an SAMJ article from 2015 with the updated recommendations for management of URTIs in South Africa they actually gave these very clearly outlined diagnostic criteria for bacterial rhinosinusitis. So any rhinosinusitis, which is often viral, will present with what we know as your symptoms of a cold. There will be some nasal discharge, a blocked nose. There might be some facial pain or pressure. Doesn't mean that you need to treat this now with an antibiotic, and we all know you can get a change in sense of smell. But when you'd actually need to give the antibiotics is when the symptoms have persisted, or there's the severe fever, or they got worse. So that's second sickening. So if they're fulfilling the suggestive criteria, amoxicillin is a perfectly good choice, but if you're suspecting there might be resistance, and that's often in children who've had recent antibiotics, or they attend daycare where there's a lot of antibiotic use, or if there's been treatment failure, you could, and certainly in complicated cases, you'd want to use amoxicillin clavulanate, and basically as short as 5 days, even though there's some literature that says go up to 14 days. Even 5 days is sufficient. Longer if you're worried because it's a younger child, a younger infant, or they seem complicated, obviously. And only if there's type 1 penicillin allergy suspected from the history should you consider using something different. You can use second or third generation cephalosporins. You can use levofloxacin because it actually comes in a syrup that would be taken by younger kids. Thinking of the macrolides and azolides, there is a concern for developing resistance and already resistance. So I just think azithromycin is used a lot these days, and I don't think there's enough evidence to say that this should be the first choice. Then the sore throat, because that's quite often what people present with, and I'm putting tonsillitis in inverted commas because it's very, very often called tonsillitis when it probably isn't. So I think we must just be strict about what we're calling pharyngitis versus tonsillitis, and obviously you can also get pharyngotonsillitis. It doesn't really make a difference because both can be caused by viral or bacterial infections, but I think we need to be accurate when we're describing what we see. And obviously we must bear in mind someone might have had their tonsils removed, so all you're going to be able to comment on is the pharynx. I think it's important to think, is this viral or bacterial? And what are we really worried about in this patient and for the greater community? Why do we want to give antibiotics? In terms of viral pharyngitis, sore throat is one of the most common presenting complaints at health providers. And we all know people want treatment, whether they've paid for it, whether they haven't paid for it, they have come there, the parent has brought that child and they want something. And we feel that pressure as treatment providers. The largest group is children and adolescents, and then they say that there's a second population who can get sore throats over 40s, but that it's sometimes different causes. In kids, the majority of viral causes, rhino, adenovirus, influenza, coronavirus, and especially in under 3s, viral causes are the most common. So any age can get a viral throat infection, but under 3, it's usually viral. It will almost always get better within a week or 2. And these viral pharyngitis will not complicate. And one needs to remember this. That's not to say that if they have rhinovirus or RSV that they won't have a concurrent chest involvement, but the throat itself is not the problem. And I think everyone especially wants to treat someone who is 1 year or 2 years old because they're young and you're worried that they're going to get sicker, but they're probably the least at risk of any problems. Obviously, if a throat infection is worsening or continuing, we might worry about other viruses like EBV or CMV. And obviously, in immunocompromised patients, there's a much broader differential, like Tom presented the other week. But this is basically what a viral pharyngitis will look like, with erythematous fauces and a bit of a granular appearance at the back. And usually we know to ask about, or we will see that this patient also has a low-grade fever, a cough, hoarseness. They may have conjunctivitis. They would have a blocked nose, rhinorrhea, and it would have happened over a few days probably. Whereas bacterial pharyngitis, tonsillitis, this is the main worry usually. And the most common organism is group A strep, Strep pyogenes. And this organism is less likely going to be a problem in under 3s. Either they're less likely to have an infection due to this, and if you were to swab them and find Strep pyogenes, it's most likely just colonizing that area and not the cause of the symptoms. So the dangers of a bacterial pharyngitis are acute rheumatic fever, scarlet fever, and possibly systemic infective complications. And it is actually contagious, which I've often found quite interesting, because there could be a lot of you will often find just one person with a strep throat, but not everyone's going to get it. A lot of people are just colonized, but it is contagious. And if you aren't colonized and haven't been exposed before, you may also get sick from it. So it's pretty important to treat this if you suspect it, and certainly if you prove it in children over 3 years of age. There are various scoring systems. One is called the Centaur. There's also the fever pain score. And I'm not going to show you all the numbers, but essentially it looks at the likelihood of it being bacterial, which is higher if there isn't a cough, if there are tender anterior cervical lymph nodes, if there's fever, if the onset was sudden, if the age is between a certain age group, so 3 to 21, you're more likely going to worry. And if you see an exudate, so if you just see that dry red throat, that's less likely. When you see pus, it's more suggestive. And then you will look at these as being unlikely, where you can watch, possible where you might want to swab if you have that resource, and very likely where you would probably just treat. So yeah, you can do a throat swab for a culture, or rapid tests are available. And then sometimes they talk about giving a provisional prescription to say to the parent, if the patient isn't better within 24 to 48 hours, they can then go and fill that prescription. That is not always going to be followed, or a possibility in all settings. So the treatment, I'm sure many will know, according to your IMCI, most sore throats, symptomatic treatment, throat lozenges, things like that. And be assured that the majority to all will resolve within 1 to 2 weeks, no matter what the cause is. If you feel that there is an indication to treat, you've looked at those criteria, you're dealing with that age group where acute rheumatic fever is your worry, then you should treat them. You can give them something as basic, I can say, as penicillin or amoxicillin, and the advice is 10 days. This would be one where we say finish the course, don't just wait till they're feeling better. And the 10 days is advised by previous acute rheumatic fever prevention studies. It's unlikely everyone usually does, and they probably shorter will prevent rheumatic fever. But if you've decided this person needs it, at least prescribe it for 10 days. If they're allergic, you can get away with azithromycin or clindamycin, or possibly second-generation cephalosporins. And you will know in retrospect also this was probably bacterial, because they should be better within 1 to at most 3 days. Please always be aware, especially in young kids, if they're not improving, if it's one unilateral tonsil that's enlarged, obviously if there's any airway involvement, if you see a membrane, or if there's other systemic features, you either need to think of something else, consult ENT, and consider imaging. And if there are ulcers, that's also still likely viral, but we will cover that just now. Otitis media is another common reason to visit healthcare providers, and this is the second most common after upper respiratory infection presentations. In fact, you could clump it within upper respiratory tract infections. The most common risk factor is having had a cold in the last week or so. There are other risk factors, especially daycare, allergies, and environmental smoke exposure. The organisms are similar to the ones I already mentioned for the rhinosinusitis, the bacterial sinusitis. And otitis media is the most common in the first 6 to 24 months of age. Well, from 6 to 24 months of age. In fact, like 3/4 of children will have had an otitis media by the time they reach about 3 years of age. The symptoms might be helpful where they actually have otalgia, but when they're young, they don't really necessarily. If they pull their ear, it might not actually mean you have an ear infection, and they might not pull their ear, but it might be suggestive They often have a low-grade fever, and they often the parents will describe them as just not sleeping well at night and being very irritable. So our concerns, the potential pitfalls is that it's often overdiagnosed because doctors want to find something that they can treat. So they'll say, that eardrum's red, let's treat this. And they may see a red tympanic membrane, but that could be from, it's just an early infection. Could be from crying, it could be from fever. Often you don't see the TM, the tympanic membrane, because of wax. But reassuringly, this is less likely going to be associated with an infection because the wax, the heat of the inflammation would probably melt that wax. And it's often difficult to examine a miserable child. So there's a lot of pressure to make a diagnosis here. And then there's often underdiagnosis because you can't see correctly or you just didn't get a good look in the ear. Best investigation is to look with an otoscope, and they talk about pneumatoscopes, but I don't think we always have one available. But that would be ideal. So then the question is to treat them. So some have fluid behind the tympanic membrane as part of any viral infection, upper respiratory infection. So if you see what is obviously an acute otitis media with pus behind the tympanic membrane where it's red and bulging, and you can see the fluid, then you should treat it probably. Why should we treat it? It's painful. The child is often ill looking. They're miserable. So you would shorten the duration. And we, especially in our setting, especially in the state sector, we aren't sure if a patient can come back quickly enough, and we don't want to have the complications of the extension to the nearby vital structures. And we're obviously going to be especially concerned if they're immunocompromised, lower income settings, and malnutrition. So some countries actually advise immediate antibiotics, especially if you're certain of the diagnosis and if there's limited access to healthcare or if there are risks of complications, you would treat immediately. And especially if it's recurrent, certainly if they're neonates, but obviously be aware neonates need more investigation and consideration. Also, if they're unvaccinated. Others advise you can watch and wait for 48 hours because it's usually viral, and even bacterial infections could resolve spontaneously. You must manage the pain, but you need to know that the parent will be able to monitor the child and return or collect antibiotics if they worsen. So in South Africa, they say you can watch and wait if they're over 2. American Academy of Pediatrics say between the age of 6 and 23 months. If it's only unilateral, the temperature is below 39, you can also watch and wait. Again, your choice will be very similar to the rhinosinusitis, amoxil, possibly, quite often we use coamoxiclav, amoxicillin clavulanate. The course only needs to be 5 days if it's uncomplicated, but if they're younger than 2 or if it's complicated or recurrent, go for 7 days. Again, this desire to give everyone azithromycin, not recommended due to resistance concerns. Refer to an ENT if they're not settling within 2 to 3 days. Grommets, consider referring for tympanostomy tubes if they've had more than 4 confirmed episodes in a year. And it's important also to know if you see a tympanic membrane that's got grommets or has perforated and there's pus coming out of there, you can give topical antibiotics, possibly with steroids if they have grommets in situ, and decongestants and antihistamines are not recommended. My father often says all children are born with a congenital absence of grommets, kind of making light of the fact that if you send a child with an ear infection to an ENT, they will very likely get a set of grommets, whether it's necessarily required or not. I am, okay, hopefully going to make it. The worrying cough, I think, is also quite a common concern, and these all are very relevant, I think, now in the middle of winter. There are different patterns of coughs, and coughs, like I mentioned, are a part of most upper respiratory infections. The natural history will be resolution, no matter how much it upsets the parents. Obviously, we know that some coughs signify pneumonia, and this pneumonia can happen whether you're immunocompetent or immunocompromised. So obviously, when there's hypoxia, chest findings, that's a different story. We're just now talking about the cough. And one, especially when the rest of the upper respiratory tract infection has resolved. So there are different patterns. When you see multiple viral in waves, that's either from exposure at school or preschool, or possibly even intermittent because of hyperreactive airways. then you would worry about pathological coughs. I mean, you would worry it is pathological when it seems to last, get a bit worse and worse over time. Whereas quite a lot of the time we see a cough that's worse in the first week or two and then lingers, but eventually will settle. So we expect most to last not more than, well, up to 2 weeks and even up to 4 weeks, but hopefully improving. We worry about a chronic cough that's lasting more than 4 weeks. There are various different causes. And just the quality is quite helpful. We know dry coughs might mean asthma, and productive coughs, or in kids, we talk more about wet coughs because they don't actually expectorate, but that will also help us. So we do want to know what the quality of the cough is, and then it would mean different things. This is just a picture to show how many cough syrups are out there and how few actually work, so they're not really our answer. So when should we give antibiotics and when do we worry? Assuming there are no other concerns, obviously we would worry if there's weight loss or anything to suggest TB or something more sinister. We know when we should consider asthma, when there's a history or other features or no response to steroids or bronchodilators. And if it's occurring every day and night as well. But of particular importance is the prolonged wet or productive cough, and this can mean protracted persistent bacterial bronchitis, and this is when it's lasted for more than 3-4 weeks. If they happen to have a chest x-ray, which many will have by this stage, it should be normal. There should be nothing to find on examination, really. And these patients respond to 2 weeks of antibiotics, it's been found. It's a common cause actually of cough, and it was described initially in 2006. It's thought to be a combination of a bacterial infection which is lingering. It's probably produced a biofilm, and there is an inflammatory response in the larger airways, well, the bronchi, not the bronchioles though. And it's seen especially in children under 6 years of age. They find, other than it being triggered by a change in position, there's nothing much more to find except some secretions in the chest. And they should respond to at least one course of antibiotics, a 2-week course, and some do require prolonged treatment or recurrent courses. But keep in the back of your mind things like if they aren't improving or if there's other concerns, think about disorders of immunity, cystic fibrosis, or anatomical abnormalities. One slide on acute gastroenteritis, because this is very common in children. Obviously, this isn't always an infectious cause in children. But infections do include viruses, bacteria, as well as parasites, but the parasites will more likely cause a prolonged persistent diarrhea. Treatment is almost always supportive. The idea is to maintain hydration, avoid antiemetics and antidiarrheals. Zinc has been proven to help in to get better slightly fast and to prevent another bout of gastroenteritis soon. And antibiotics are really only used in cases of dysentery, usually. And then the controversy here, I think, as an outpatient is, should we advise these parents to buy probiotics? It's likely that they do no harm, but there is a chance in severely immunocompromised patients that you are giving them organisms orally. And I just think the great danger here is misinformation and just telling people to go and waste their money. Everything you read will show you that it may shorten the duration of diarrhea, but we're talking possibly by 25 hours, and there is no conclusive proof. So it always depends on the cause of the diarrhea, the strain, and the amount and the duration of probiotic taken. So the quote that I took was that the evidence is not strong enough for the WHO to recommend them as a standard treatment. Lastly, mouth, hand, foot disease, because I had to end with the toes, but you would probably know it more as hand, foot, mouth disease. This is, especially at the moment, I'm sure everyone knows someone who might have had it, a child, obviously. It's a common recognizable childhood illness. There is a particular picture to it. The issues here are, it can be a bit sometimes confused with other conditions. You might be worried about potential complications, and then there's the concern about, can this child go to school? It's usually a benign, self-limiting illness. It affects mostly children, but sometimes can affect an adult, and it can affect people more than once if they get a different virus that also causes the picture. It affects always immunocompromised or at risk, but immunocompetent children as well. It's not vaccine preventable, and we know it's easily transmitted. The usual cause is a member of the enterovirus family, and Coxsackie A16 is the most common candidate, the most common organism, but other enteroviruses can cause a similar picture. There are other Coxsackie viruses, for example, Coxsackie B, and certain enteroviruses, one in particular is A71, which can cause a rash, but the more severe manifestations are more prominent. And it can cause myocarditis, pleurodynia, sometimes respiratory manifestations, meningitis or encephalitis, or even a polio-like syndrome. And it is a very common cause, actually, enteroviruses are a common cause of when we admit neonates with possible sepsis and meningoencephalitis as neonates. But normally what we will see is the rash without any of these other features. The spread is fecal-oral because it is an enterovirus. Sometimes it's respiratory spread. Basically, the virus multiplies in the gut and disseminates to other organs. And they will generally present with malaise, GIT symptoms, usually the typical rash, or possibly sometimes just a maculopapular rash, but often the palms and soles are involved. So I think this is very important. We saw a patient like this the other day on our post-intake, probably did need admission because they needed fluids. So this is your big difference, herpangina versus herpes, herpetic gingival stomatitis. So herpangina is really when you're just seeing the ulcers on the back of the pharynx, the soft palate. And this is usually a little bit, it extends to a little bit older than your herpes group. But it can span 1 to 7 years, usually in late summer, early autumn, winter. And they usually have a fever, a sore throat, and you will see these ulcers on the oropharynx, and it's just supportive treatment versus herpetic gingival stomatitis, which tends to be in younger kids, starting a bit younger, anytime, and the gingiva are very involved and painful. And then you might want to give acyclovir. So this is typically what we see. You must get a good look though. So that would be herpangina, which is just the mouth. The hands and feet are spared. And then hand, foot, mouth, you will typically see the lesions. And in herpes, you're going to see a lot more anteriorly and possibly involving the gums, and might even see 1 or 2 lesions around the mouth. In hand, foot, mouth, you might also see some lesions around the mouth, but I thought this was a good picture because this patient looks like they're smiling because they're not that sick, whereas your herpes gingival stomatitis are very miserable and painful. So what's important to know, although you can get complications with some enteroviruses, or you could call them severe manifestations, it's very rare and not usually with the strain that causes our typical hand, foot, mouth picture. Try and get a good look in that throat. That's the important part. Only consider herpes if it looks like herpes. And I should have said, sorry, only consider acyclovir if it looks like it's herpes and if it's early enough. If they've had these lesions for more than 4 or 5 days, it's unlikely really going to make a difference. We must always manage the symptoms because they're very painful. So they might need to be admitted sometimes for a brief time for some fluids intravenously, and give things with topical anesthetics and anti-inflammatories. We actually just made our own magic mouthwash in the ward. And that the children can go to school or daycare as soon as they're feeling better with hand, foot, mouth disease. And we just would encourage schools to practice hygiene, hopefully all the time, but especially in these outbreaks. Sharing may not be caring, and to remember hygiene, hand hygiene. Thank you.
Great stuff. Thank you. Thanks, Judy. Good revision for many of us. I've certainly learned a lot. And I'm sure very, very helpful. I've had a lot of people asking about, sending the slides. We will put it on the YouTube channel, so have a look at that in a couple of days' time. This talk will be on there for those who are interested in it. Thanks, Judy. Really nice overview. One of the questions I was just thinking of, when you were displaying it, I know you were saying that for the acute bacterial sinusitis, you think sort of 5 to 7 days may be enough for most people. Is there any group you would go on for 10 to 14? Because I think that's still in the guidelines, isn't it? Or am I wrong?
In our pediatric guidelines, they actually don't say that long is necessary. I think it would appear if they're younger, you might go on longer, but certainly if there were complications. So, if this child required a a scan for some reason. But then we're talking orbital cellulitis now, if they had proptosis or any meningism, anything that we were more worried about would certainly go on for longer, complications. And I think if it's recurrent or if they aren't initially responding, then we might go on for longer.
Sure. But I mean, in general, for most cases.
The move is, yes, shorter is actually fine.
Cool.
Yes.
And then another question I had, just again, which probably, again, most of my questions will probably sound stupid to pediatricians, but from me as an adult physician, it seems interesting, is that the group A strep obviously, is well known to be less common under the age of 3. I was interested you saying that that's true even if they're colonized with it. Is there any reason that you know of why doesn't the sort of very young transition between colonization and infection, or are they just much less likely to even be colonized?
They probably are less likely to be colonized, and I don't know exactly why. If there might be other organisms sort of overpopulating the area, I'm not really sure why they wouldn't be colonized. But yeah, it doesn't seem to cause pathology, and even if it does, it doesn't trigger that rheumatic fever concern. Oh, good. Gary, yes, he's there to save me, I think.
No problem. You can unmute, Gary.
Cool, thanks. No, my understanding is they're actually more likely to be colonized, and it's actually the colonization that seems to, in some way, reduce the inflammatory response and to actually reduce the likelihood of symptoms. I don't understand the immunology. I remember looking at it at some point. But colonization rates are actually highest in infancy and young childhood. And then when they get it later on, that's when they're more likely to be symptomatic.
Okay, interesting. Yeah, fascinating. Just looking through the chat, is a comment from Helen about children who cough in the absence of other symptoms. Have you heard of any anti-helminth therapy? I'm guessing you're going to say no, but interested. I mean, is that a thing that you've come across where people give that?
No, I mean, I can understand. I think that would be one that really is probably lasting longer than 4 weeks, kind of thing. And you might have a pertinent travel history or other features, maybe. And certainly, I think after 4 weeks, you would start considering, let's do an X-ray, and maybe you would possibly have tried an asthma inhaler at some point there. But you might even do blood. So if there's a history that's suggestive, and we see an eosinophilia, if that's what you're referring to, but it's certainly not standard, it's not advised, and not for just a cough that's been there for 2 to 4 weeks. Yeah, not just.
I'm going to say that's probably the number one cause of symptoms in children with cough.
Yeah,
so,
yeah.
Sorry, it's not helminths, but that some children present with cough. Others, you'll be giving anti-helminth therapy for 80% of the population.
Yes.
Let's have a look. Okay, I think that's it. But yeah, thank you again, Judy. Really, really helpful, and I really appreciate it. And I think you've done a great job of a lot of these really common infections. Thanks very much.